behalf of the ESSM, I'd certainly like to thank BAUS for inviting us to give this session. We are heavily committed to education, and indeed if you wanted to do an exam in sexual medicine, there is one that is just around the corner, and the four speakers that you have today all teach on that and are heavily involved in the program. You can see from the topics they're slightly different, but very important issues. I'll get off the stage because we've got two psychologists, so I need to give them time to speak. And the first, Dr. Evie Karana from Greece, is going to talk to us about female sexual dysfunction.
We're going to negotiate about it.
Negotiate. Yeah. Does it exist?
Okay, well, hello. It's very nice to be here. So we're going to talk about current and ongoing debates on female sexual functioning. And specifically about the role of desire in various sexual response models. So we're going to have a small competition, and we're going to see who's going to win. Is it going to be Masters and Johnson and Kaplan who described a more traditional sexual response model, or is it going to be Rosemary Besson and her newer description of her sexual response model? But first of all, let's see what is a model. So basically, a model is a graphic representation of a phenomenon, and it has three important elements. One, it's supposed to describe the ingredients of the phenomenon. The second thing that we expect from a model is a description of the relationship between the ingredients. And the third thing is that it has to be tested, otherwise it's a conceptual framework. So let's have a look at a sexual response model. These are the ingredients. And first comes desire, then comes arousal, then comes orgasm, and then resolution. And this was tested. We had some evidence by Masters and Johnson. So basically, Masters and Johnson described a sexual response model that would actually start with an arousal phase, an excitement phase. And a few years later, Helen Kaplan introduced the concept on desire. So she said that desire, which she described it as sensations, and they were strongly connected to sexual fantasies and sexual thoughts. She said that this is what triggers the sexual response. So this was a model that was based on findings from women's sexual response in the lab. It's a linear model. It has a start and an end. The desire phase is discrete. It's a discrete stage, and it's also necessary for the rest of the stages to follow. So Kaplan talked about sexual thoughts and fantasies, and this was actually the model on which the vast majority of research that we have today was based on. But of course, in order to avoid criticism, we have to be or do nothing, and therefore there was criticism. So first of all, is sexual desire a discrete stage of the sexual response? Well, in clinical practice, it's often very difficult to distinguish between desire and arousal, but also women report that it's difficult for them to distinguish desire from arousal. And also, if you see the FSFI, which is a female sexual function inventory, the gold standard for us, the subscale of arousal correlates highly with the subscale of desire. And then, is sexual desire a necessary stage? So is it necessary for a woman to have sexual desire in order for her to respond sexually? Well, in one study, sexually healthy women that were 40 to 60 said that they are frequently unaware of spontaneous sexual thoughts. In another study, 80% of sexually active menopausal women were satisfied even though they had low spontaneous sexual desire. And in a study with a very large sample of 2,400, approximately half of them reported rare or absent spontaneous sexual desire, but the majority of them were satisfied and they had no arousal problems. So now I'd like to ask you, do we eat because we are hungry? Now, I eat for many reasons. I guess most of you do as well. I eat sometimes because I'm hungry, but also sometimes because food is in front of my face, or because I'm bored, or because I'm Greek and this is how we express our love. But something similar happens here, because sexual desire is not the most frequently reported reason for which women have sex. Actually, this very well-known study showed that there have been 235 different reasons for which women may have sex. Some of them have to do with love and intimacy or physical pleasure, but some of them have to do with non-sexual goals. So for example, I will have sex with my partner because I would like him to agree on babysitting during the weekend. Or I will have sex with my partner because I'm going to be away from home to a congress, so I want to make sure that I'm guarding him and he won't go with another woman. So another question is, does appetite come with eating? Right. Mine does. So does desire precede arousal? Well, desire sometimes precedes arousal, but sometimes follows arousal. Many women report that sexual desire is experienced after they have received sexual stimulation that is pleasant to them. And in this study, women with and without sexual dysfunctions reported desire as a response to sexual stimuli, and this is what we call responsive sexual desire. So the basic criticism of the Masters and Johnson-Kaplan model was that sexual desire is not a discrete stage of the sexual response, it's not necessary always, and sexual desire may be experienced after a woman has received sexual stimulation. So based on this data and some more, Rosemary Basson, who was also a consultant to the American Psychiatric Association's DSM-5 committee, proposed a new model, according to which a woman can start by being neutral, but she may think of reasons. She may have some reason for which she thinks that she would like to engage in sexual activity, so some kind of motivation. And if she wants to engage, then she will be open to receive some sexual stimulation. And if this stimulation is arousing, then some arousal will come, which will be followed by more sexual arousal and desire, responsive desire. And if this is a pleasurable experience, not only physically, but also emotionally, then this pleasure, this arousing experience will be the motivation for her to engage in sexual activity next time as well. And during the cycle in different parts, spontaneous sexual desire may actually pop up in different parts. So basically, desire in women is not always automatic, and sexual desire does not have to precede arousal. It can be experienced together with arousal. So in your opinion, who is the winner? Nobody? Still confused. Well, let's see what women have to say. This is the first study that actually asked women to tell us. So we see that we had equal proportions in women. No wonder we can't figure out what's going on with women. Equal proportion of women said that they endorsed the Master and Johnson model. So they start off with excitement. Some said they start off with desire, as sensations of desire, and some said that they start off neutral, but they have motivation. And what's interesting here is that women with a sexual problem had a higher probability to report endorsing the Basson model. Now, this is a study that is the newest study in this field, and we see similar results over here again. And again, the women with a sexual dysfunction had a high probability to report the newest Basson model. And actually, Anna Maria Giraldi did this study in men as well. And again, we see that no single model of sexual response could describe men's sexual responses. Of course, here we see that a smaller proportion compared to women report the Basson model. But again, men that had erectile dysfunction or were dissatisfied had a higher probability to report endorsing the Basson model. So, as you understand, all this eventually had an impact on the way we define desire and arousal. Now, until recently, the definition, we had two definitions. One was for hyperactive sexual desire disorder, and one was for female sexual arousal disorder. Now, the desire definition would focus on fantasies and a desire for sexual activity, while the female sexual arousal disorder would focus on arousal of the genitals, like lubrication and swelling. So, however, as we said before, a lot of women report having a satisfying sexual life, but they don't report sexual fantasies. And actually, sexual fantasies seem often to be a deliberate way of somebody to focus attention in order to become aroused, or not that spontaneous always. And also, decreased desire for sexual activity. Well, I think the picture says it all here. The lack of desire for sexual activity may be an indication of low disclose sexual desire, but not necessarily. And also emphasis on arousal of genitals. Now, this has received criticism as well, because in women, subjective feelings of arousal are not always the same as genital arousal. And Marike will talk to us about that more. So, the new DSM-5 came up recently, and here we have an influence of what I've told you, and we have a new clinical entity which actually combines interest and arousal. So what we see here is sexual interest arousal disorder in women. The good thing is that desire is not restricted to fantasies. It includes responsive desire, and it also includes interest in sexual activity. And also arousal is not limited to genital arousal, but it goes on to sexual excitement and pleasure. However, on one part, the positive thing is that, at least at a symptom basis, a lot of women have both interest and arousal symptoms, so we don't have to choose one of the two disorders. But on the other hand, some of the criticism is that it seems as if we're lumping all women in one category, while some women may have only desire or only arousal problems. And at the same time that we've gotten research showing that a woman that doesn't have spontaneous desire but has responsive desire, she's normal according to a recent criteria. At the same time, we have flibanserin that has been approved by the advisory committees. We expect this to be out soon, so we have to see how this is going to be used in the future. So sexual desire is not experienced by all women in one unique way. In clinical practice, it's necessary to educate them about responsive desire and about the circularity with arousal. And obviously, future research and our experience will provide more evidence concerning the validation of this new clinical entity and whether the benefits are more than the costs. Thank you.
Thank you, Evie. Evie, do you want to come sit on the front? Okay, we'll take some. We've got the two talks first, and we'll have some questions after. So the second talk is bridging the gap between the genitals and the mind, and Marguerite de Witt is from Maastricht, who's going to talk about this.
Okay. Good morning. I'm going to present some studies on the underlying mechanisms that can explain the impact of mindfulness on sexual arousal, so we can sort of bridge the gap between the mind and the body. Now, sexual arousal can be considered as the primary outcome variable in sex research, but it's also quite complex to study sexual arousal because it is experienced through different responses. We have a cognitive component, physical component, and these do not necessarily converge. So what is important for sexual arousal to unfold? Well, first of all, there has to be an adequate sexual stimulus that will automatically grab our attention and that will then automatically be raised as sexually meaningful. This will then automatically evoke sexual arousal responses, and the moment we become aware of these ongoing physical responses, we will further elaborate on the sexual stimulus, we will maintain our attention on it, and this will then result in subjective arousal, this actual sexual desire, which is then the result of these ongoing physical responses. And so this will then trigger the motivation to actually engage into sexual activity. So when putting these different steps into a model, it seems that especially attention here plays an important role, but also appraisal processes, so how we evaluate the sexual stimuli. And what also is important is that we make this distinction between subjective arousal and genital arousal. Now, we know that agreement between subjective and genital arousal is important because stronger feedback links between the cognitive and physical components of the sexual system will increase sexual arousability. Now, we know that men generally show high concordance between their subjective feelings of arousal and their genital responses because they have these peripheral feedback processes. They have external genitals, so they can benefit from this. They know I have an erection, so I must be sexually aroused. But women benefit less from these feedback processes because their genital response does not produce a prominent cue. Lubrication is not clearly observable. And so this may explain why women are generally characterized by lower sexual arousability. So in a way, it could be that to increase their arousability, we should increase their awareness of genital responses. We also know that a lot of sexual dysfunctions are rooted in sexual arousal problems. Often sexual arousal, lack of sexual arousal, is the core problem in sexual dysfunctions, which is characterized by deficient feedback between their subjective and genital arousal responses. So to sum up, I think that sexual arousability is determined by, first of all, an adequate sexual stimulus, attention, awareness of these physical arousal responses, and the feedback process between subjective and genital arousal. So if we want to increase sexual arousability, we have to focus on these specific components in our therapies. But when we look at treatments, the most common treatment for sexual arousal problems is CBT, cognitive behavioral therapy, which is more about cognitive restructuring, targeting avoidance behavior, using sensitive focus exercises, and so on. And when we look at treatment of female sexual arousal problems, what we often see is that they take this low concordance between subjective and genital arousal as the norm. So most treatments don't focus on the genital awareness in women, but focus on this cognitive restructuring, on the subjective arousal, without actually trying to increase genital awareness or increasing the concordance between subjective and genital arousal. Now, although we know that these CBT treatments are highly effective for sexual problems, we do know that the third wave of CBT protocols focus more on mindfulness and acceptance and commitment therapy. And while these treatments have become increasingly popular because they have been demonstrated to be highly effective for a range of clinical conditions, it has its roots in Buddhist meditation, and the basic idea of mindfulness is to focus our attention on bodily sensations, which then cultivates this non-judgmental, moment-to-moment awareness. Now, there is growing evidence now that these mindfulness-based treatments are highly effective for sexual problems. So it seems that it increases sexual desire, it decreases sexual distress, there's more interoceptive awareness, more attention to sexual stimuli, more quality of life. So it seems to be a good thing. But when we take a closer look at the evidence, it seems that there's often no control condition. There's like a pre- and post-measurement, and if there is a control condition, it's not an active control condition. So we cannot be sure what the specific effect is of mindfulness over and above the general effect of an active intervention. It's also often directed towards a specific clinical condition like endometriosis or cancer. So we still don't know much about the basic operating mechanism of mindfulness in a non-clinical sexual context. And what also is remarkable is that mindfulness is often part of a larger therapy. It's often integrated in CBT protocols, so we cannot really know what role, if any, was played by specific mindfulness interventions. So I think we need to conduct more research on these mindfulness-based only interventions to know more about the effect of mindfulness on sexual arousal. So what are these mechanisms of change here? Well, mindfulness is mainly about attention. It's regulating our attention on our bodily signals instead of these distracting thoughts. Now, this is exactly what the body scan is. Body scan means that people lay down on the ground, they scan different parts of their body, and they focus on their body, and when there are distracting thoughts, they just let go and focus on their body again. Mindfulness is also about accepting what you feel without self-judgment, without negative thoughts or negative appraisals. So when we translate this to the context of sexuality, it actually makes sense that mindfulness is a good treatment for sexual arousal problems because it targets the core determinants of sexual arousal. It's about attention to the sexual stimuli, it's about attention to your body, which is exactly the body scan, and which is closely related to sensitive focus exercises, and it's also about accepting your feelings without self-judgment. So in some studies, what I wanted to do is look at the effect of the body scan and acceptance on attention to sexual stimuli and sexual arousal. So I'm going to present 4 studies. I'm not going to go into detail. I'm just going to highlight the main idea. So 2 studies on the effect of body scan, 2 on acceptance, in which we look at mood, sexual arousal, the subjective arousal, but also genital arousal and attention to sexual stimuli. Now, I did these studies in women because especially women are characterized by these low awareness of genital arousal and low concordance. But I guess it makes sense to do this in men as well because they can also benefit from this awareness process. So what I do is I invited women to come to the lab and they watch a sexual movie, and while watching the movie they have to report on their sexual arousal. So they have this lever and then they have to indicate how much sexual arousal did you feel, and also which genital sensations did you feel during the sexual film clip. And we also measured their genital arousal using the platysmograph, the VPA measure. To measure attention to sexual stimuli, we use the computer task. So we present pictures, sexual pictures, which are then replaced by a target, and participants have to respond at the location of the target. So when it's in the upper location, they have to press right, and in the lower location, they have to press left. And so when the target appears at the same location of the picture, participants can react quickly because their attention was on the picture. But when it appears at the opposite location, they have to shift their attention, and this costs time. So the reaction times at this target give us information on how much attention participants are paying to these sexual pictures. Now, in this first first study we did, half of the participants did the body scan training. So they came to the lab, they report on their basic mood, then they lay on the ground and we do this audio tape of 15 minutes, a body scan, then they report on mood again, then they watch a neutral movie, which was a documentary, they report on sexual arousal, then they watch a sexual movie, it was a female-oriented porn movie, then they report on sexual arousal again, and then they perform the attentional task. And in the control condition, they just listened to an audio tape on the history of Europe. So what we see here, there was no improvement in mood, but mood scores were already quite high at the baseline. And what we see is that in the body scan condition, participants do respond with more genital arousal compared to control. And we also see that women pay more attention to the sexual stimuli in the body scan condition compared to control. Now, we conducted the second study because a body scan is something you have to train. So we invited participants to come to the lab, and then they trained this body scan exercise during 1 week every evening, and then they came back to the lab again. So we wanted to include a pre-post measurement of attention and arousal so that we have something to compare with. We also had an active control condition so that participants really had to do something. So they listened to presentation on healthy lifestyles instead of the body scan. And then every night during 1 week, they received an article via email on healthy lifestyles. They had to summarize this and send it back to the experiment leaders, so they were actually doing something. And we also measured genital arousal with the VPA. Again, we found that in the body scan, after this training, participants respond with more genital arousal, and we did not find this improvement in the control condition, and again, more attention to sexual stimuli. And after the body scan training, there was no effect on actual physical arousal responses. We did a third study on acceptance. So what we did here is that participants read an essay of 3 pages on acceptance of sexual emotions, and they had to apply this while watching the sexual film clip. So we did the same protocol, but now instead of the body scan, they just read something like, accept your feelings. It's important that you just accept what you're feeling. Don't try to suppress it. Don't try to distract yourself. Just feel what you feel. It's okay. In the other condition, participants had a suppression instruction. So then half of the participants received the instruction like something like, try to suppress your feelings. If you feel something sexually, just distract yourself. It's important to know how much control you can have over your sexual emotions. And then in the control condition, they just wrote on a typical Tuesday. What we found here is that participants reported with more arousal in the acceptance condition compared to suppression and control. We found no effect on attention, but this time we did find that in the suppression condition, participants reported more attention to sexual stimuli, which could be a rebound effect. If you're told to suppress your sexual emotions, you actually pay more attention to it. We did a fourth study replicating this. We also included genital arousal here. And what we see is that in the acceptance condition, participants report more sexual arousal, and they also show more genital arousal with the VPA. We also found stronger concordance between subjective and genital arousal in the acceptance condition compared to suppression and control, which actually proves what we were looking for. So what can we conclude? Well, it seems that the body scan has a clear effect on attentional processes and on genital arousal, self-reported genital arousal. So it seems that attention is an important process here. So if we're working with body scans and sensed focus, we should learn people to focus more and attend more to sexual stimuli and to their bodily signals. We did not find an effect on genital arousal, which was rather unexpected because we expected that the body scan would increase attention and arousal to the bodily signals. We did find that acceptance is an important ingredient of mindfulness because it had an effect on all types of sexual arousal. And of course, we had no clinical samples, so we should replicate this with women with sexual problems. We had quite small effects, and it would be also interesting to focus more on individual differences to see whether there are differences in this mindfulness effect. But in any case, what we can conclude is that especially acceptance is an important ingredient of mindfulness, just accepting what you feel. And for me, it was surprising to see that there is so little research on the effect of acceptance and commitment therapy on sexual problems. There's a lot on mindfulness, but there's not much on acceptance and commitment therapy. So I think we should pursue this in the future. And what I also think is important is that we do more research on mindfulness-only interventions, because and try to compare this with mindfulness as part of CBT, for example, so that we can really focus on the mechanisms of change, because it could be that a full-blown mindfulness intervention will be more effective than just doing these single mindfulness interventions like a body scan or an acceptance instruction. So I think this is definitely a line of research that we should pursue in the future, because I think mindfulness is a promising treatment for sexual problems. Thank you.
Thank you.
Are there two excellent presentations? Are there any questions from the floor? Rika, I've got one question for you. Did you look in the demographics of the women in your study, whether it made a difference in the relationship history or profession or?
Yeah, we did. We always have demographics in it, and there was no difference whether they had a relationship or not. Yeah.
Interesting.
And the body scan is one visit?
Yeah, it's just 15 minutes in which they learn to focus on their body, and then we have an audio tape. We give it with our patients, and then they can exercise it every. It's something that, well, we see here in the study that the effects of one-time body scan is already enough to increase sexual arousal. So the most ideal situation is that you practice it every night during several weeks, so that you focus more on your bodily signals.
But not too much.
Yeah, maybe.
Well, because too much porn does the opposite.
Yeah.
There's no arousal.
Yeah, that's true.
Yeah. Okay.
Okay. Our next speaker is Dr. John Dean, who many of you will know. He's a frequent commentator and contributor in the world of erectile dysfunction. He works in the Southwest and in London. He's going to tell us about sex beyond the missionary position, which is certainly news to most of us, I suspect. John.
Indeed, and therein lies the rub, and perhaps we should be paying more attention to the rub, in fact. We have some very effective treatments for a wide range of sexual dysfunctions, in erectile dysfunction, in sexual pain disorders, in men, premature ejaculation par excellence. The focus is very much on penovaginal penetration. And we tend not to think too much about sex beyond penovaginal penetration when people come to speak to us in sexual medicine practice seeking advice. And I hope over the next 15 minutes to persuade you that perhaps we do need to think about some of the other things as well. So, first of all, my few disclosures. None of these companies have probably ever done any research which has looked at sexual behaviours which people find pleasurable and practice widely as part of their clinical programs, because instruments like the IEF focus upon vaginal intercourse. So, let's look at these other sexual behaviours. First, a few words about language. What do you call these other behaviours? They're variants to penovaginal intercourse. They might be considered unusual, atypical, non-conforming. But that can apply to anything that is not penovaginal intercourse, which is prescribed as the right sort of sex by many cultural and religious authorities. We tend to think of people who practice other behaviours as being part of a sexual minority. It's a very large minority, as I will demonstrate shortly. And we consider perhaps people who do other things than penovaginal intercourse as having some form of unusual preference, or perhaps, if they're really unlucky, we'll lump them in with people who have a paraphilia or disorder of sexual preference. Terms like sexual perversion and sexual deviance have no place in sexual medicine practice. So we have penovaginal intercourse approved, we have these other behaviours rejected, and typically, if they're not usually mentioned at all, but may be denied. So, A couple of words about orientation and sexual identity, because this too is important. Orientation refers to the idea that we're someone to whom we are sexually or romantically attracted. We must remember that orientation and behaviour are not the same thing. There are many gay, bisexual and lesbian people who practice a range of sexual behaviours, as do heterosexual people. In fact, the only behaviour that is unique is penile-vaginal intercourse, which is unique to heterosexuals, or at least to couples who exhibit heterosexual behaviours. Sexual orientation is not behaviour. Behaviour is with whom I have sex. Now, if you happen to be an inmate in a prison, your options are limited. So your sexual behaviour will be same-sex, but your orientation and sexual identity may remain heterosexual. To whom I want to have sex, we all have our fantasies, and fantasies come down to who do I fantasise having sex with when I'm being realistic. Who do I fall in love with? With which community do I identify? Many men and women identify with the heterosexual community in Western world, and certainly if they live in conservative societies, such as in South Asia or the Middle East, they may identify with a community which is actually not in congruence with their sexual identity, either because they deny it or because the risk of belonging to that community is high. Sexual identity is the orientation with which I identify, and there is a difference between those. Identity, orientation and behaviour may be congruent or incongruent, and even more confusingly, may be fluid over time. Now, there is evidence that sexual orientation is affected by immunological, genetic, endocrine factors. It's largely not social learning and is neurodevelopmental to some degree, and probably to a very large degree. But there is evidence that it can be flexible during the life cycle, that you are not born heterosexual or homosexual and stay that throughout your life. Certainly amongst gay men and lesbians, there is some change in attractions and behaviours during the course of the life cycle. And it is more common in lesbian and heterosexual women than it is in gay and straight men. The consequence of this is that we need to remember that sexual behaviours and sexual orientation, the desire for them may change during the course of life. The only group where there doesn't seem to be any change is amongst bisexual people. Bisexual people get a really raw deal. Nobody does much research on them. They're a group which has a low visibility, who are rejected by straight people and by gay and lesbian people as well to some extent. Social attitudes are changing, but people are often more reticent to reveal sexual interest in either sex or in no sex at all than they are to heterosexual and homosexual sexual intimacy. There are a range of attitudes towards the various behaviours that people will want to enjoy as part of their intimate and sexual lives. There's varying degrees of social disapproval, which are often influenced by culture, belief and religion. Masturbation makes you go blind, according to some authorities. Looking back on some of the Victorian and earlier treatises, it was thought that it also caused madness and ultimately death. Attitudes have changed somewhat. Oral sex, anal sex, extramarital sex, BDSM. I'm going to focus a little bit on BDSM in a minute. Behavioural stereotypes in minority populations are really sort of not not very helpful. I think it's very unhelpful to talk about gay sex, because the only thing that gay men do that heterosexual men don't do is penile-vaginal intercourse. And even gay men may quite enjoy, may engage in penile-vaginal sex sometimes, even if it is not their normal sexual preference. Paraphilic social reaction rather depends on the object of sexual interest. If your interest is in exposing yourself, you'll get some social disapproval. If it is in leather, you're in leather or rubber, you may well find that you get a slightly different reaction. If your interest is in children, the social reaction is very different indeed. More on paraphilia at the end of this talk. I think it's very unhelpful to stereotype people by their behaviours. Straight sex, gay sex, lesbian sex, bisexual sex. Most of my work is now in gender services. Trans sex, whether it's binary or non-binary trans, is a very interesting area to work in, and I think perhaps a topic for another day. Preference and identity don't always match. Preferred behaviours aren't reliably associated with a specific sexual identity, and we need to avoid thinking in terms of heterosexual and homosexual behaviours. Identifying orientation in a sexual medicine consultation is important. Ask questions. Tell me about your relationship. Are you living with someone? That will allow the person you are interviewing to be able to reveal the gender of their partner more comfortably than perhaps you asking, are you married, or which is rather value-laden, or are you homosexual? Going on to some of the behaviours, masturbation, it's practiced by 95% of men and by 71% of women at some time in the past in a British population survey in the 1990s. I just wonder about the 5% of men who aren't telling the truth there. It is a common activity. It is a useful source of sexual relief. It is more commonly practiced in people from higher socioeconomic groups and people who are better educated. In men, the more partnered sex they have, the less masturbation. For women, the other way around. The more partnered sex they have, the more likely they are to masturbate, provided that they're orgasmic. Oral sex. Most commonly in single and cohabiting couples, 88% of men, around 80% of women admit to oral sex sometime in the past year, around 2/3 in married men and women. Anal sex, this is a slightly later survey, the second NatCell survey, around 10% of men and women cohabiting and single admitted to having anal sex as part of their sexual repertoire. But looking at data in the United States, the figures were much higher. In 2005, 40% of men and 35% of women admitted to having heterosexual anal sex within the past year. This is a common sexual practice. We need to think of safer sex, giving safer sex advice to our patients who engage in oral and anal sex. Oral sex, things like condoms and dental dam, which is a film which you can place over the anus or vulva, can improve the aesthetics and also protect from sexually transmitted infection. For those who wondered why gents' toilets contained lager and lime flavoured condoms, all has now been revealed. Anal sex involves more than just penetration with a penis, finger, vibrator or dildo. Can include insertion of hand or even the forearm, or oral contact as well. A little on BDSM. BDSM is derived from combination of these various initials: bondage and discipline, dominance and submission, sadism, masochism or sadomasochism. These relationships generally involve unequal roles being taken within a sexual relationship. One partner is usually dominant, the other taking a submissive role. These may be thought of as minority activities, but are in fact really quite common. It encompasses a range of practices, which are largely focused on role-playing, perhaps on restraint, ritualized humiliation. These things, not to be paraphilic, are consensual. They're not a paraphilia. There's a degree of ritualization which protects those involved in them from real harm taking place. They may take place within a relationship, an established relationship, and there is also a BDSM subculture which involves often communications through the internet for people who have particular interests and preferences. I said these things are reasonably common. Now, we have my eyesight, unfortunately, is getting lousy these days, but the prevalence of BDSM activity, around 20% in a 2005 study carried out by the Durex organization, had handcuffs, blindfolds, things for the practice of restraint as part of their sexual repertoire, things that they used to enhance their sexual interest. Sort of activities, bondage, often the woman are more commonly in the dominant role. Many men, about half men, express interest in the United States of being tied up during sexual activity. Discipline and punishment form part of this repertoire of activities. Dominance and submission describe the psychological dynamic. What's exciting about this is it's not the sort of the equal sexual relationship. The couples who engage in this activity enjoy the difference in their roles. They enjoy being dominated or punished, or they may enjoy dominating and administering punishment. It is, as I said before, different from sexual sadism or sexual masochism disorder, which are paraphilias. BDSM is more common amongst gay men. It is commonly practiced to some extent by heterosexual couples, although some couples find that you find fewer married couples taking part in this. This type of behavior is often not compatible with long-term relationships. But the important issue here is that it's not about peno-vaginal sex. If someone has a BDSM preference or a masturbation preference or an oral sex preference, then they need us to focus on enabling them to engage in that form of sexual intimacy and pleasure, which is legal, which brings them satisfaction and relationship satisfaction and psychological well-being, just as much as if we were helping them engage in peno-vaginal sex. Now, I'm going to leave it to Kobe to identify all of this. Our next speaker is going to be talking about piercing pain and porn, which should be quite fun, but there are a number of sexual activities here which are part of the BDSM game. As I say, it's about play. You say it's a sex play rather than a perversion or paraphilia. Sometimes occurs in long-term relationships. There are also professional practitioners as well who sell their services. And there are various safeguards, contracts, rules. A lot of BDSM clubs, for instance, don't allow alcohol in order to reduce the risk of permanent harm or death. Paraphilia is a different beast. To be diagnosed with this, the individual has to have a compulsion for a sexual behavior which causes them distress or may cause psychological damage, distress, injury or death to another person or be against the law. A very different case. They should not be confused with the sort of atypical variant sexual behaviours which I have just mentioned. They're very uncommon in women. It's generally a man's issue. Do not confuse paraphilia with sex play. Consensual adult activities are not paraphilia. Last slide, just to give you, is how common is paraphilic ideas? Research done in Germany a few years ago by Ahlers and colleagues, a community sample, not a clinical sample, from a German city, 62.4% of men reported having a sexual fantasy associated with a paraphilia. Of those, about 9.5%, the paraphilia involved prepubertal children. that only involved sexual fantasy. About 4% actually were committing sex offences, that they were child sex offences, and were acting out their fantasies. Paraphilic arousal daydreams are really very common. We need to be aware that of these unusual sexual interests, and certainly where there is distress involved or where there are child protection issues involved, we need to involve the appropriate agencies in order to protect children from harm. So, lots of things. Think beyond the missionary position. There's a lot more to enjoyable sex than the missionary position. I'm sure perhaps some of you have discovered them. Even if you haven't yet discovered BDSM, some of your patients probably have. Variety is the spice of life. Thank you very much.
Thank you, John. John, do you want to, we'll have questions for these two at the end of Kobe's talk. Last but not least, Kobe Reisman from Amsterdam. The 3 Ps, no, it's not the old 3 Ps. I see Tom and Nicholas up there. It's a slightly different variation on that. So we've got porn, paint and piercing. Kobe.
Yeah. Thank you. Good morning, everyone. Thank you, David. Thank you, Duncan, for the invitation to be here. We are going to talk about another Joyce's subject. As you see, sexual medicine is huge, is large, is so interesting, and you are all welcome to join us in the next Congress of the ESSM. I will tell you at the end of my presentation. Anyway, let's start with porn. Do we like porn? What do you think? Yes, we do. Yeah, that's clear. Just to give you an estimation, this is how much the porn industry is involved. $13 billion, which is much more than what Google and Microsoft doing in their revenues. So we like porn very much. So we need to think about it in our variety, John, what you just told us. And how much we deal with it. 12% of the websites are with pornographic intent, which it means 24 million websites about pornography, and not only men are interested in porn. One of the 3 porn viewers are females, luckily. But there's also other aspects. Children nowadays are exposed to porn the first time at the age of 11, so that could be could have some consequences. And 20% of the men admit that they do it on work, at 30% of the female do it at work, so it's still a business, and the day that mostly porn is watched is on Sunday. Think about it. There are differences between males and females about porn. Women like more the interactive one, and they enjoy more the shared sexual activities. They want to talk, like the psychologists that you heard about. Women like to talk. But males are more visual orientated, and they are enjoying more the solitary activity. Is it bad or is it good? For everything in life there is bad and good, also for porn. It could have some risk, because it could give some difficulties with your morals and social and relationship problems. It could fill a gap in the real world. It could create a virtual reality with something like women are always getting an orgasm and they never complain. Where it could be, I don't know, but it's also could increase the health risk behavior. On the other side, it could increase our sexual repertoire. It will make acceptance of what we think something like bizarre, of spicy, of different. And it could also increase pleasure, certainly in a long-term relationship. But there is terms like porn addiction. What is porn addiction? Actually, we don't really know. There is no definition in the DSM-5, and we lack a defined criteria. So when we do some research about it, we don't know exactly what we're talking about. But you can think that it could be a problem if someone spends excessive amount of time viewing, or if it have significant impact on their daily life. Is it real addiction? There are some people who said it's totally different from alcohol, gambling, or drug addictions. There are certainly an out-of-control behavior, and it could be compulsive or impulsive, and sexual desire dysregulation. What we know is that the people with impulsive or compulsive disorder are more prone to get problems from these activities. And in the United States, the estimation is that there are about 200,000 Americans which are porn addictive. It means that they define it more than 11 hours a week spending on watching porn. And in this group of people, there is more loss of jobs, loss of support, and financial problems. Why it's not going further on? Okay. And if you think, am I porn addicted? You can check yourself, because you can ask yourself, do you feel more consumed by the pornography? Are you risk your job? Are you risk your relationship? What your partner will feel about it if she know or if he knows about it, which will be of the risk. And now we're looking at porn in inappropriate places, publics, library, coffee shops, work. Think about those issues. But at your office, as urologist or andrologist and sexual medicine persons, you can meet all kinds of different persons who come with these questions. They could be real addicted, according to the definitions, or they could be recreational users with some worries, or there can be people with sexual problems who use porn and say that porn is the cause of their problems, or they use porn to solve these problems. And is it really a concern and it causes sexual problems? In general, we think quite often, if you watch a lot of porn, you will get some problems and you will have sexual difficulties. And recent study from Stuhlhofer and his colleagues showed that pornography does not seem to be a significant risk factor for younger men's sexual desire, erection, or orgasmic problems. So it's okay if you like it, if you do it in a proper time and without any risk for your job and for your normal life. But when they come to your office and real people with real problems, they usually minimize the consequences. Oh, it's not so like that, and it's not so often, and it's not so much, but mainly they lose their job, they are isolated from relationships, they lost the partners, or at least they got ultimatum from the partners. And the only way to deal with these people is when they have real desire to stop these activities. Otherwise, you get lost. Let's go to another juicy subject, and that's the piercings and the pains, the tattoos. What are piercings? Actually, they are fistula-like tracts. You can remove them. Sometimes it will have some consequences when you remove them. I will show you some of them. But tattoos are there to stay. They are permanent, and even if there are some treatment and lasers, etc., they're still being there. If we look in the medical literature, we only found about 150 articles about it, so we don't know a lot about it, but we see it in our practice. And there are not really baseline figures about all those things. Anyway, we as urologists need to deal with it like the dentists or the ear, nose, throat doctors do. They have nowadays some protocols for the treatments of consequence of piercings and tattoos, and certainly the urologists need to do it as well. It's not an act that people do just like that. It's take on average 6 months to take the decision to take a piercing, certainly genital piercing. It's take a few weeks to heal. When they do a genital piercing, they have at least 1 to 3 days of some bleedings. It takes sometimes a year till they get a real tract, real fistula. And they need to avoid unprotected intercourse, swimming pools, jacuzzis for a few weeks. So they need to do a lot of effort to have those things. And if we look at it, in each culture, there are some piercings and tattooing. In most of them, it was a rite of passage from adolescence into adulthood, but in the modern time, is more an identity or fashion issue and those things. It's really popularized in the modern world by the British Mr. Sebastian, is a very famous one, and reports in the literature said a prevalence of 1 to 3% of the population with genital piercing more often in men than in women. In England, there is only one cross-sectional survey of households with more than 10,000 participants of 16 years old and older, and body piercing was apparent by 10% of them. Body piercing is more prevalent by women than by men, but genital piercing of 1.3%. It means that about 200,000 people have genital piercing in the UK. So each one of us as urologists will meet them in the clinical practice. Why they do it? That's not because of a rebellious act, and there are some beliefs about enhancement of sexual desire and sexual pleasure. There is no evidence concerning male genital piercing. Concerning female genital piercing, there is only one study who saw positive correlation between clitoral piercing and desire and arousal. What people say when they have it is that it helped them to express themselves. They feel unique and they feel being myself. That's quite an obvious reason to take it. When we talk about tattoos and hair removals, this is more common in young individuals, mostly sexually active, and it's really influenced by peers and media. That's different from piercing. What we know about characteristics of people with genital piercing, that there is significant risk-takers behavior, seeking new experiences. There is no evidence for high prevalence of sexually transmitted diseases, but when they do it in unprofessional way, there is some concern about the transmission of hepatitis B, C, or HIV. There is a lot of self-esteem issues, eating disorders, and certainly in the group of females with genital piercing, there are significant percentage of abuse in the past. Look at types and name. The most apparent one called Prince Albert, and it's named on the Queen Victoria husband, Prince Albert, that some people believe that he was wearing such a piercing. You have also the reverse one, and I show you some of the possibilities with the names. You don't need to remember, but some of the patients say, I have that and that. Then you know what they talk about. For the females, there are also a lot of variants. Sometimes they combine it also with tattoos, and it's Princess Christina. We don't know really where it's coming from. Some say from the Netherlands, some say from Scandinavia. This is one of the most apparent one, and the triangle and the labial and clitoral hoods are most apparent. In those cases, they don't have any damage normally to the urethra. They can damage the clitoris, but not the urethra. But you can imagine that in all those cases, they certainly damage the urethra, and we need sometimes to deal with it. The complication rate is quite high. For body piercing is 33%, and for genital piercing is 44%. The complication came because they didn't do it by a professional one, so the technique is poor. The aftercare was lousy. The body change after wearing long-term piercing, or partner damage, which also can happen. They don't come to us very often because they fear that we don't know nothing about it, or they fear that we are going immediately to say, take it out. And that's not what they want to do, because they did a lot of effort to have a genital piercing. The most apparent complications are bleeding, infection, fistula of structure, keloid or hypertrophic scarring, allergic reaction, urine flow interruptions, and even problem with the condoms. There are some anecdotes of trauma to the vagina and the urethra. I saw one of them in my practice. Choking on swallowed piercing, teeth chipping, trapping between the partner teeth, paraphymosis, priapism, and here is one of a guy who wanted to remove his Prince Albert, and the consequence was actually a fistula. And he needed to have a large repair of that fistula, like you do by hypospadia, for example. This is another nice thing. The guy came to complain that he lost his piercing during sexual act, and you see two parts of the piercing in the cervix. Oh, we needed to remove it. It could happen. The complication rate, probably you don't see it very well. There are 4 studies about male and female, and then you can see the percentage of complication is quite high. What do you expect for us? To help them to solve the complication and not remove the piercing. So what we need to do, in case of localized cellulitis, you don't need to remove the piercing because it's helping in the drainage. Given local antibiotics, advise on warm compresses, frequently cleaning, and it most of the time goes away. But if it will not resolve after 5 to 7 days, sometimes we need to do an incision and drainage, and in that case, they will need to remove the piercing. Radiographs are not a problem except if it's metal and they are going to the MRI, and be careful when you do some operation to use the electrocautery and to touch the piercing, because it will cause a wound, and a serious one. And remember, we need to know the specific difference, the risk factors, and how to deal with it, and how to consult those guys with genital piercing, because they want to wear it and to keep it. And our attitude is very important, because otherwise they go to get an advice from the internet or from local advisories people who give lousy advices and some health problem for these guys. Don't take them out immediately because they want to keep them in. And last but not least, I invite you to visit our website of the ESSM, where we have information about the European School of Sexual Medicine. It's an excellent initiative, excellent course started by John Dean, and we follow it with 10 days course on all aspects of sexual medicine. We have fellowship exams according to European Union of Medical Specialists, and I would like to invite you to come to the ESSM meeting in February 2016 in Madrid. Thank you very much.
Thank you, Kirby. So any burning questions? We're slightly running over time. Yes, Nigel.
You mentioned that sexuality was a fluid thing. Is it directly influenced when people undergo transgender surgery? And also, is there any evidence that the pattern of response of people changes with surgery?
Most trans people, certainly at the time of transition or around peri-transition, whilst they may consider sex might be important from the future, they're generally not terribly focused on sexual behaviour, because there is a mismatch between their body development and usually their image of what good sex should be for them. It's important that when counselling patients on hormone therapy and genital surgery, that they consider what their sexual options are, what their likely preference for sexual behaviour, sexual partners are going to be in the future, because making choices may limit their options for the future. I think that in general, I don't think that there is some fluidity of sexual identity, but I don't see it as a major issue amongst trans people. Most trans men who are birth assigned female sex, but have a male identity, want to have a heterosexual relationship, i.e., as a trans man will have a woman partner. And I observe the prevalence of same-sex relationship, homosexual relationships, to be about the same in the trans population as in the general population. I don't think that actually having surgery makes any difference to their sexual identity or their preference for sexual behaviours. But what they do need is proper counselling beforehand to make sure that they don't make choices which restrict their options for relationships and sexual pleasure in the future.
Thank you. PJ, number 2.
I wanted to ask Professor Eisman a question. He touched on pornography in young men and how it causes sexual dysfunction. And in my clinics, I'm starting to see quite a lot of young men with this problem, but you didn't actually touch on the best management option for them. I wonder if you might be able to comment on that.
The best management, you mean for the group of looking at themselves as addictive or with sexual problems? Two different things.
The ones with the addiction or the potential addiction.
In the group of that describe themselves as addicted, and if you see a really an social consequence for the daily life, you need to treat them, and you will need to have it in a multidisciplinary way, because it will need, in most of the cases, also a kind of psychotherapy. You will need to differentiate, is it an pure addiction because of some problem and avoiding reality in daily life, or is because of compulsive or impulsive sexual disorder, which is a totally different approach. To say to a person, don't do it, will not help. Okay? So you will certainly need some kind of form of psychotherapy, otherwise it will not succeed. So as urologists, we cannot do it alone.
Thank you very much. I'd like to thank our colleagues from the ESSM for such a great session and for your participation. Thank you.
Thank you.